I will be talking about the recent WHO update on parathyroid tumors 2022. The blue book is about to come out, or maybe it's already out, but the last US and Canadian Academy of Pathology meeting in the Endocrine Path Society, we did a special symposium devoted to all endocrine tumors in this WHO update. So I'm delighted to present to you some data on parathyroid tumors that is being proposed in this new classification. So bear with me if I have some technical issues, but hopefully this should go smooth. So as we all know, we have 4 parathyroid glands normally, but I've seen 5 at times, and sometimes you may not be able to find all 4 of them. They develop from the dorsal buds, the 3rd and the 4th pharyngeal pouches, and majority are located in the neck, but often you'll find them in the mediastinum, you'll find them inside the thyroid, and anywhere else. And I've been called for a frozen section by a cardiac surgeon doing a coronary artery bypass graft. Found a nodule which turned out to be a parathyroid adenoma. But it was a hyper-functioning, or I would say non-functioning adenoma at the time, because patient did not have high PTH or didn't have high calcium levels, and later on was found to have mild hyperparathyroidism. The glands, what's more important from pathology point of view, you usually weigh the glands, and I think it's good to know that the normal weight of these glands is about 30 to 40 milligrams, and combined total 4 glands should not be more than 120 milligrams. Anything above 50 milligrams is considered abnormal. This is the normal histology of the parathyroid. You see stromal fat, and then you see parathyroid cells, which may be in different phases of their physiological activity. Some are more active, like these chief cells, and then we have the oxyphil cells, which are the same cell but in a different phase of physiological activity. But we do classify them as chief cells, oxyphil cells, water clear cells, and then transitional cells. They do not have any clinical significance as far as pathology or lesions of the parathyroid are concerned. So this used to be the classification. Most of the time we get called to consult on parathyroid cases is because of hyperparathyroidism. Before WHO 2022, we had primary, secondary, and tertiary. The causes of primary were considered to be adenoma, which is the most common, 85 to 90% of the time, and then hyperplasia, which is 10 to 14%. Now, I've circled this here to show that this has changed now. The new name for this is multiglandular parathyroid disease or multiglandular parathyroid adenoma, and we'll talk about that later. And then rarely, thankfully, you have carcinomas and atypical adenomas. And again, this name is also changed. Instead of calling it adenoma, the proposal is to call it an atypical parathyroid tumor, because we don't know what its behavior is. Nothing has changed in secondary hyperplasia, which is a result of some primary underlying disorder like chronic kidney disease or malabsorption causing hypercalcemia and compensatory reaction with primary or secondary hyperparathyroidism. Tertiary, when parathyroid becomes autonomous in the background of secondary hyperparathyroidism. Some nodule may become autonomous and then become tertiary hyperparathyroidism. That's the reason pathology gets involved in it. And the way the patient comes is, in the case of primary, they'll have a high serum calcium levels. Secondary, usually it's low serum calcium. Then to compensate for that, the parathyroid is going to overdrive the produced calcium. And tertiary, you have high serum calcium levels. And incidence of parathyroidism, hyperparathyroidism is increased because of the introduction of these autoanalyzers. We do clinical chemistry tests these days. For example, before 1974, the incidence used to be 15 per 100,000 patients, and after 74, it's like around 100 per 100,000 patients. So clearly, if you do more testing, you'll find more lesions, and that's the reason hyperparathyroidism is also increased in incidence. The way, as Dr. Mishra would know more than anyone else here, who is a surgeon, that we do a pre-op evaluation of these patients, usually do an ultrasound scan or a system scan before you plan exploration. In ultrasound, you could see a hyperechoic lesion, It's more sensitive for adenomas and multi-gland disease. And similarly, on a systematic scan, you can see uptake. It's also taken by salivary glands, but if you look at it 2 hours later, you can see one of the glands is lighting up, suggesting there is a single gland disease. Combination of ultrasound and systematic scan is very sensitive, especially for single adenomas. And then if you need to do other studies, you can do a CT or MRI scan, but less commonly used. I think what's very important for management of parathyroid disease during exploration is intraoperative PTH levels, which is very useful. We'll talk about in a minute. So, management of parathyroid gland abnormality, what is our role as pathologists? Obviously, you come into picture when there is surgery going on during intraoperative evaluation. We do a frozen section to confirm parathyroid and diagnosis whether it's hyperplasia versus adenoma versus carcinoma. This thing is difficult, adenoma versus hyperplasia, because it depends on how many glands are involved. Adenoma versus carcinoma is less of a problem. Most of the time, surgeons will make a diagnosis of carcinoma. They'll say that it's hard to take the gland out, so that's very helpful. The role of fat stain, we usually don't do these days, but there was a role or value in doing mild or minimally hyperplastic glands in which the intracytoplasmic fat is depleted. So what we're looking for is fat within the cells, intracytoplasmic. What's very valuable is intra serum PTH levels. So before starting surgery, you get a PTH level drawn. You take the gland out, and after you think you've taken the gland which was causing hyperparathyroidism out, you do another PTH level 15 minutes or 30 minutes later, and if it drops down to below 50% of the baseline, then you think that the gland that was producing the hyperparathyroidism is out. So that's just a basic background of parathyroid pathology and how we as pathologists come into play in regarding management of these patients. So what has changed in WHO classification this year? First thing that has changed is nomenclature. So we're calling things with a different name. For example, hyperplasia in the setting of primary hyperparathyroidism is no longer called hyperplasia. I think this is referred to as multiglandular parathyroid disease or multiglandular parathyroid adenoma. And the reason, we'll talk about that in a minute why. Parathyroid adenoma is still the same. Nothing has changed there. Atypical adenoma of the parathyroid is now referred to as atypical parathyroid tumor. Again, emphasizing the importance that we really don't know how these tumors are going to behave, so we cannot call them adenoma, which implies it's a benign tumor. So it's what you can say, a borderline tumor of uncertain malignant potential. Nothing has changed with regards to the nomenclature in parathyroid carcinomas. What has changed is some recommendations on how to work up these cases of parathyroid tumors and carcinomas. There's a new category of tumors that they have classified as what's referred to as parafibromin deficient parathyroid neoplasm. So I think that again we'll talk about the importance of doing parafibromin levels or expression by immunohistochemistry to start with in parathyroid tumors. Nothing has changed in the nomenclature for secondary parathyroid hyperplasia or tertiary hyperplasia. Let's look at this case I had recently, like 2 or 3 weeks ago. This 27-year-old female had a history of autism spectrum, otherwise healthy, presented to the emergency department with a fall and fracture of the femur. So that's why she came to the hospital. When they drove the labs in the emergency department, she had very high serum calcium levels, 15.7 milligrams per deciliter. High PTH, hypophosphatemia, and low vitamin D. She did not have any prior history of high serum calcium level. This is the first time she's had blood drawn. Family history, mother with multiple sclerosis, otherwise no significant endocrine neoplasia, sister with autoimmune alopecia, no history of hypercalcemia or MEN or jaw tumors in the family. She had a neck CT which showed a 4 centimeter right inferior parathyroid, heterogeneous and hypervascular. And additionally, in addition to that 4 centimeter, the other glands were, they said, mildly enlarged. So there was one big gland and 4 other glands were mildly enlarged. He was taken to the operating room for neck exploration. The baseline intra-op PTH was 1537 picograms. She had right inferior parathyroid removed, which was her largest gland. So PTH dropped to 346 picograms after 15 minutes and 158 after 30 minutes of removing the enlarged parathyroid. Now, clearly you can see this 158 is below. It's almost like 10% of the original level, but still, because imaging had showed other glands, the surgeon was obliged to look at other glands. So I explored the same side, and we removed 4 and found to have 5 parathyroid glands identified, out of which 4.5 glands were removed. And intra-op PTH fell to 75 picograms after removing 4.5 glands. And I checked the values post-op. 2 days after post-op, it was 5 picograms. So clearly, what was causing the hyperparathyroidism, all the parathyroids enlarged, abnormal were removed. This was the first gland, that's the largest, which weighed 3.5 grams. It was attached to the thyroid. Here's the normal thyroid, and you can see there's a capsule between the parathyroid and the thyroid. But there's no real invasion of the capsule. It's just very smooth, fibrous capsule, no invasion into the thyroid gland. If you look at the cell, it's composed of chief cells and some oxyphil cells mixed together. What it also showed was a lot of cells with large atypical nuclei or abnormal nuclei showing hyperchromatic cells, but no mitoses. No mitoses were identified, and this is quite commonly seen endocrine organs referred to as endocrine atypia. It does not really imply a neoplastic cell population. So that was one gland, which was like 3.5 grams. The gland number 2 we got was 165 milligrams, clearly enlarged, normal weight being 50, so like 4 times, and very hypercellular, so also abnormal gland. Gland number 3 was 264 milligrams, also enlarged and hypercellular, but not as big as the first one. Gland number 4 was almost like twice the weight of a normal gland, but still hypercellular and enlarged. So we got 4 glands, all enlarged, different sizes, all hypercellular, and usually they do a biopsy of the 5th gland just to confirm that they've documented 5 glands in the neck. And that showed a little bit of cellular parathyroid cell with adipose tissue. So, given these 4 glands enlarged, the diagnosis in this case is multiglandular parathyroid disease. I checked the post-op course just yesterday. I saw that it was complicated by hypocalcemia. Gone down, there was one level of 7, but now it's stabilized to 8.5 milligrams on calciferol and calcium. And once calcium stabilizes, the plan is to do genetic testing in the coming weeks. So that's the real reason I'm presenting this case, and probably why WHO committee suggested this additional workup and how pathologists can help in triaging these patients to get a more definitive diagnosis with regards to the underlying genetic abnormality. Another reason they're considered to be not hyperplasia is they're considered to be clonal proliferation. They're associated with MEN1, MEN4, and the newly described MEN5 syndromes. We'll talk about that in a minute. They can be asymmetrical and occur in asynchronous manner, and you can see our case is asymmetrical. One gland was big and the other glands were smaller than the first one. The nodular proliferation of chief cells and other cell types, and they often lack rim of atrophic parathyroid around the lesion, and we didn't see any atrophic or normal parathyroid around the lesion. There appears to be a germline susceptibility-driven process and may need genetic testing, and that's why I think we come into play recommending these patients to undergo genetic testing to rule out which is actually may affect patient care in the future. The main syndromes that are associated with multiglandular parathyroid disease, as we all know, are MEN1. We all know the MEN1 gene, the protein menin, which is a tumor suppressor and has been known for a long time. MEN4 is almost same as MEN1, but with a different gene. This protein product is P27, cyclin-dependent kinase inhibitor, and also a tumor suppressor. And MEN5, which is still under investigation, not well recognized, but it has a MAX gene, which is like a MYC-associated protein factor X, and promotes cell proliferation and apoptosis. So these are the syndromes that we would like to know if these glands, large glands, these patients may have one of these syndromes, so other things can be kept in mind. So the importance from our point of view is that pathologists can provide additional value to genetic testing and triaging by recognizing these morphological and immunohistochemical harbingers of MEN1, MEN4, and MEN5 syndromes, and also CDC73 related manifestations, which we'll talk about later when we talk about adenomas and carcinomas. So that's good. You can identify these abnormalities, maybe good for genetic counseling, and also if patient in the future comes up with some other lesions of other organs. So that was multiglandular parathyroid disease or adenoma. I wish I was there personally. Usually you want to see if you have any questions or pause for a minute just to think about what has changed and why it has changed. So, but that's not the case here. So I will pause for a few seconds if you guys want to think about it a little, see, before I move on to the next case. So this is a 54-year-old female with history of chronic kidney disease, presented with high PTH level, bone, muscle pains, and cardiac symptoms. So the incidence of secondary hyperparathyroidism due to chronic renal disease has really gone down nowadays. You no longer see those very significant pathological fractures or brown tumors or renal osteodystrophy. They usually symptoms are mild, bone pains and muscle pains, but nevertheless they do occur because of all the addition of phosphate binders and calcium mimetic drugs. I think the incidence is much less now. This patient had all 4 glands enlarged, almost 3 are almost the same size, 4th is a little bit smaller, and the histology showed nodular proliferation of parathyroid cells, showing hyperplasia of all the glands, And these hyperplastic glands in chronic renal failure or secondary hyperplasia can show degenerative changes, hemorrhage, fibrosis, and also other changes like calcifications. There's increase in parenchymal mass resulting in proliferation of chief cells, oxyphil cells, and transitional cells. Multiple glands are involved, and most are polyclonal. But there are some studies, and if you look at individual nodules within these hyperplastic glands, they may be clonal. And that's one of the reasons drove the WHO, especially in the setting of primary hyperparathyroidism, consider them as neoplastic proliferation. But in this case, we know the cause is secondary, so hyperplasia still is a recognized entity in the setting of secondary hyperparathyroidism. So they're symmetrical, they can range in size, fat stains, intracytoplasmic fat can decrease or deplete it, maybe diffuse or nodular, and you can see hemorrhage, fibrosis in large glands. So that is secondary hyperplasia. What about parathyroid adenoma? The terminology, nomenclature is still the same, what it used to be. This is the most common cause of hyperparathyroidism. There may be some predisposing factors like radiation exposure or familial or heritable disorders that we should always keep in mind. Occurs in 5th or 6th decades of life, a little bit more common in males and females. Majority present with hyperparathyroidism, minor subset reported to be non-functional. And sometimes those non-functional cases get to notice when you do surgery for other reasons. Maybe sporadic. For example, I've seen cases in which they see a neck node with thinking it's a thyroid nodule. They do an FNA, it comes back as follicular neoplasm. You take it to surgery, it ends up being a parathyroid adenoma. So those cases, they're not really producing PTH to the extent that patient you'll see hypercalcemia, and that's how they get picked up. So maybe sporadic or familial as part of a hereditary syndrome. The single glands are involved, and most commonly it is the inferior glands, could be superior sometimes. Rarely they're good with two glands, referred to as double adenoma. And there are case reports, which is a little stretch. Obviously, this is before the new classification came out of triple adenomas. These cases may be now classified as multiglandular parathyroid adenomas in the setting of primary hyperparathyroidism. The glands have thin capsule with a rim of normal parathyroid and outside. And they can be variants like oncocytic lipodenomas, water clear cell adenoma. And we'll see some examples of that. This is the case we had a few years ago. Very smooth cut surface. The important thing about adenomas is here's the nodule with the capsule, and outside you can see a rim of normal or atrophic parathyroid. And the adenoma itself can produce follicles like these. Almost looks like a thyroid. Sometimes it's a challenge to distinguish thyroid from parathyroid, especially on just on a frozen section. But as I tell my residents, that you can always look for calcium oxalate crystals that you will see in a thyroid, but not in frozen section and not in a parathyroid, because these are pseudo follicles, but they have the same kind of material that you see in the colloid, so it's difficult on a frozen section. Here again, you can see this follicular architecture of the parathyroid, rim, and then outside you can see normal parathyroid. Some areas could be more cellular. You can have different kinds of cells. Some of them are oxical cells, some clear cells. And here you can see some larger cells. They could, again, like we saw in our case, you can have some atypia of these cells, but that doesn't really mean anything. But no mitotic figures. Rarely you can see a mitosis. Variants include microadenomas, oncocytic type adenomas, water clear cell adenomas, and lipodenomas. And here is an example of microadenoma. You see nice solitary nodule, follicular architecture with endocrine atypia, oxyphil cells, part of the lesion. Another case with the interface between the normal and the abnormal nodule. You can see the cells are very oxyphilic, pink cytoplasm, referred to as oxyphilic adenoma. These cells have a lot of mitochondria, that's why they have this pink, finely granular cytoplasm. There's another gland which was enlarged, like this weighed actually 7 or 8 grams, about 5 or 6 centimeters, with very clear, foamy cytoplasm, clear cells. And sometimes it's a question in the frozen section room, is this really a parathyroid or is it some other clear cell tumor, like a renal cell carcinoma or some other? So sometimes what we do have to do immunohistochemistry to prove that it's a parathyroid. So you can do stains that will support parathyroid origin, like PTH. You can do chromogranin is positive, and obviously it'll show negative for if it's a clear cell carcinoma like renal cell antigen and other. Here's an example of lipoadenoma. You can see adipose tissue mixed with the parathyroid cells. Like here, it's a lot of fat. Looks like lipoadenoma, and the cells look oxyphil and chief cell type. So there are different types of parathyroid adenoma. Again, I can pause for a few minutes for you to think about what I've just said, and then we can move on. This is a 46-year-old male with hypercalcemia, was found to have hyperparathyroidism. Ultrasound and systematic scan showed enlarged right inferior parathyroid, a right inferior parathyroidectomy, and biopsy of the right superior parathyroid. Intraoperative PTH dropped to below 50% of the baseline after removing this gland. And here you can see the gland, 2.5 grams in weight, 2.2 centimeters, thick fibrous capsule, a lot of fibrous bands intersecting the tumor, very uniform population, clonal population of cells, very bland-looking cells, no mitoses, no atypia, no real necrosis in the tumor cells, but a lot of thick fibrous bands in areas of hemorrhage. Like here, you see this pigment is hemosiderin, so there was some remote hemorrhage, fibrosis, more of the same hemorrhage and fibrosis. There's a different case. In this case, it was a 59-year-old with high serum calcium, 3.5 grams of parathyroid attached to the thyroid here, but not infiltrating it. And I know 12 years later, checked her history, she's fine. And this is referred to as atypical parathyroid tumor, tumor of uncertain malignant potential. The reason to label this such as it requires a long-term follow-up. So I think one important point I'd like to make here is you only make a diagnosis rarely. That's one thing. You only make a diagnosis when you're not sure is it atypical parathyroid tumor or a carcinoma, not adenoma. So there has to be a higher threshold for suspecting atypical parathyroid tumor. Plasma of uncertain malignant potential. The previous name used to be atypical adenoma. Now WHO 2022, the preferred terminology is atypical parathyroid tumor, and for the reason that we don't know how this is going to behave. It has worrisome histologic features for carcinoma. That's why we want to call it atypical, like intratumoral fibrous bands, monotonous sheets of cells, a little bit of atypia, microscopic capsular invasion, but no transcapsular invasion. That's important. Necrosis on hemorrhage may be rarely present, again, because of mechanical reasons, and occasional mitosis may be found, but not any of these features, which is like unequivocal features of malignancy. This peritumoral vascular invasion, perineural invasion of the adjacent soft tissues, metastasis, and mitoses greater than 5 and 50 high power fields of 10 millimeters square, or Ki-67 index of more than 5%. So this is absolutely, if you find any of these, you call it a cancer. And again, it'll be supported by the findings from the surgeon who will say that this tumor was attached to the soft tissues, which was difficult to dissect out of the neck. The atypical parathyroid tumor is a study from 2002 by Dr. Ron Delalis, and you can see all these tumors have these features that are described, and they have an average follow-up of 7 years and no recurrences in these. So sporadic, they can occur in familial settings, serum calcium somewhere in between parathyroid adenoma and carcinoma. And again, as I said before, this is only reserved for neoplasm with atypical features for which the differential diagnosis is parathyroid carcinoma, not a parathyroid adenoma. Talk about parafibroma and immunohistochemistry a little later, but it'll help in predicting the outcome of long-term follow-up. And it looks like this may become a routine in all parathyroid tumors because you want to see how it can assist in prognosticating these patients. So routine germline CDC73, which is the gene for parafibromin, is required or may be required in parathyroid neoplasm, especially atypical adenomas and carcinomas. Parathyroid carcinomas are thankfully rare, like less than 0.005% of all cancers. If you look at all primary hyperparathyroidism from the world literature, it's about 1 to 3% in different studies, and less than 1 per million population in the general population. So it remains a rare cancer, but incidence has increased over the years and maybe due to increased serum calcium screening and less stringent guidelines for parathyroidectomy for asymptomatic patients. These are some studies that I looked at a few years ago and looked at our own data from UMass. In our 20-year experience, we had about 400 hyperparathyroidism primary, only 4 were malignancies, so 1%. And all the other studies are in the same range. I know I looked at this study from India in which they looked at the Indian primary hyperparathyroidism registry, like 2.2% had parathyroid carcinomas in 22-year period out of 547. There were like 12 cases of parathyroid carcinoma. So it's a rare tumor, but nevertheless, it occurs more common in 5th and 6th decades of life. They usually present with very high serum calcium levels, palpable mass in the neck, vocal cord paralysis. All these things, if present, are pointing towards a malignancy. Recurrence of hyperparathyroidism short time after surgery. The surgery tumor is adherent to the surrounding tissues, like I said. It's difficult to dissect, and microscopically, the thick fibrous bands, capsular invasion, and vascular invasion. This is the common age, 5th and 6th decades. There are no predisposing factors, but rare cases may be associated with MEN1 syndrome. What's more important is mutations in the tumor suppressor gene HRP2 or CDC73. And that is actually nowadays almost required to do this germline testing if you see a deficient protein expression in the tumor cells. CGH, you'll see loss of 1p and 13q chromosome. There's loss of heterozygosity of chromosome 13. All these are related to the RB gene, the BRCA gene, which also become important in downstream signaling for these tumors. Here's the histology. You see thick fibrous bands going through the parathyroid and outside the parathyroid. Here's the skeletal muscle or neck tissues outside the gland. You can see it's infiltrating the tissues. You can see the capsule of the tumor intersected by the tumor. This was attached to the thyroid. You can see there's vascular invasion outside the tumor, peritumoral vascular invasion. Mitosis can be rarely seen. Although you can see mitoses, but those are really, like I said, the 5 in 50 high power field, which is not a very high number if you look at compared to other tumors. So there's relatively slow growing tumors. See different kinds of changes. You can see this vascular perineural invasion outside, nuclear atypia, hyperchromasia, necrosis. The recommendations of WHO 2022 for parathyroid carcinomas is that we should completely submit the parathyroid specimen for histology and do multiple deeper recuts to make sure that we've looked at all the capsule and the surrounding tissues. Count the mitoses in 10 high power fields or 10 millimeters square, perform Cas67 and parafibromin stain, and then other immunohistochemistry like APC, galectin-3, PGP 9.5, and HTER and P53. Make a point here that there's no magic marker that can tell you it's cancer or not cancer, but a panel may help in challenging cases if you have multiple antibodies, they can all work together. You have a parafibromin deficient tumor that requires gene sequencing as parathyroid carcinoma, a potentially hereditary disease associated with hyperparathyroidism, jaw tumor, or isolated familial hyperparathyroidism syndrome due to germline mutation in CDC73 gene. So I think possibility of germline susceptibility should be considered in all patients with parafibromin deficient parathyroid carcinoma, even in the absence of suggestive personal history, because it may be important to do a genetic counseling on these patients if you find mutation in the CDC73 gene. This has seen increased risk in benign parathyroid disease and up to 10% of carcinomas, you can see this. Gene product is parafibromin. We have antibody against, and you can do immunohistochemical stain to look for parafibromin deficiency in tumors. So there's a high rate of CDC73 mutations in parathyroid carcinoma. You can see, like this study showed 10 of 15 cases had mutations, out of which 3 were germline, and against 6 of 7 cases. So there's a very high incidence of mutation of CDC73 in parathyroid carcinomas. Approximately 70% of them may show. So if you do a parafibromin level, you might see loss of parafibromin immunoreactivity in this subset of patients. And that can be assessed by immunohistochemistry. And 30 to 70% of carcinomas may show reduced or absent staining in the carcinoma cells. And the way parafibromin works or functions in these parathyroid cells, you see it downregulates cyclin D1 or the CCN D1 gene that encodes cyclin D1. and c-MYC. So this inhibits cell proliferation. It also stimulates apoptosis. In addition to inhibiting apoptosis, it stimulates apoptosis and inhibits RB. We know RB inhibits cell cycle progression because it's a tumor suppressor gene. So if you look at parafibromin, it will affect both these pathways, RB causing cell proliferation, inhibiting cell proliferation, and then not able to upregulate cyclin D1 causing increased cell proliferation. So you have high tumor mutational burden, high copy number alterations, and high risk of recurrence and increased cell proliferation. This is a picture from one of the papers in which you can see this is parathyroid carcinoma, atypical adenoma, parathyromatosis, adenoma, and hyperplasia. And if you look at parafibromin, it's lost in carcinomas and it's positive in these other benign lesions, as opposed to galectin-3, which is positive in carcinomas and atypical adenomas and negative in adenomas and hyperplastic lesions. Ki-67, accordingly, is increased in carcinomas and shows low immunoreactivity in adenomas and adenomas. The loss of expression is at least suspicious of malignancy, if not diagnostic. And most studies recommend molecular testing for HRP2 gene mutation if you see loss of parafibromin on immunohistochemistry. And that's why WHO has come up with another category of this tumor in the nomenclature, what they call parafibromin deficient parathyroid neoplasm. So if you find a tumor that has negative for parafibromin, but it's logically not a carcinoma, you should label it as such, do a gene sequencing in these patients. And if it is atypical adenoma, these tumors may behave in a more aggressive manner. It's occasionally seen in adenomas, but more frequent in atypical parathyroid tumors and very common in carcinomas. So if you see a parafibromin deficiency in atypical parathyroid tumors, it is a worrisome feature and may suggest an aggressive behavior. So how do you work up these cases? So you do histology, no atypical features, parathyroid adenoma, you do a parafibromin stain if it's positive, no risk of recurrence and no need to do any further testing. If it's negative, no risk of recurrence, you may consider constitutional gene sequencing. If it's atypical parathyroid tumor, if it's positive for parafibromin, there's very low risk of recurrence. But if it's negative, it has low risk, but you should perform CDC73 gene sequencing. And if there's a carcinoma, it's positive or negative, it doesn't mean high risk of recurrence, then you should perform CDC73 gene sequencing. So this is the proposed triaging of parathyroid tumors according to the WHO 2022. This is adenoma. This is atypical adenoma and parathyroid carcinoma. As you can see, parafibromin is positive in benign. It may be positive or negative in adenomas and usually negative in parathyroid carcinomas. And these other markers also help, but they're not absolute. Ki-67 is another good marker that you should always do. In these cases, actually is recommended by WHO, which is high in carcinomas, usually more than 5%, and little bit raised in atypical adenomas or atypical parathyroid tumors, and not very high in benign or adenomas. Example from the same paper, the WHO classification paper, parafibromin in adenomas is retained, PGP is lost, APC is retained, galectin-3 is negative, cyclin D1 is another marker that is typical for adenomas, it's positive, and retinoblastoma protein shows like a wild type immunoreactivity. Carcinomas, you can see PGP is positive, there's high Ki-67, parafibromin is totally lost, and APC is also lost. So I think these stains can help. Parafibromin, Ki-67 are two more commonly used stains that can help. As far as molecular studies in parathyroid tumors, we talked about MEN1 gene. You can see germline mutation in multiglandular parathyroid disease. And in subset of adenomas, you can see somatic mutation. CDC73 or HRP2 gene, which encodes parafibromin, that's another thing that should be done. And if you find that a subset of atypical parathyroid tumors and carcinomas, they may suggest a more aggressive behavior. Cyclin D1 expression is seen mainly in parathyroid adenomas. And then calcium calcium sensor receptor and vitamin D receptor, mRNA gene, they're also involved in parathyroid adenomas and carcinomas. They're the genes that really function like a brake pedal, like they brake the proliferation of parathyroid cells when they come in contact with their ligands like calcium and vitamin D. It's downregulated in parathyroid adenomas. The genes that you can do or look for is p53, Gadre kinase, TERT, and dicer, but these are all more like research protocols. So the way they put together is, if you look at the parathyroid lesions, there are three basic clusters: the hyperplasia cluster, mostly hyperplastic parathyroid lesions; CDC73-driven cluster, which is the parafibromin-driven cluster, which is hereditary and sporadic, seen in adenomas and carcinomas; and the MEN1-related cluster, mostly adenomas or multiglandular parathyroid disease. The bottom line is there's no clear-cut recommendations of molecular workup in the new WHO 22 classification. So I don't want you to all leave this conference today, go to your hospitals, and ask your hospital administrators to get all these tests to be done. It's not really recommended at this point, and it's maybe not needed also for what may be more important is CDC73 mutation parafibromin IHC. That's what we do. We plan to at least do this in all parathyroid tumors, and then if it's positive or negative, take it to the next step, especially in tumors. For example, if it is a primary multiglandular parathyroid disease, those patients will get appropriate genetic counseling and genetic testing. But for tumor evaluation, if you have a specimen, you don't have to do all these tests that I'm just talking about. Most of the time, you can make the diagnosis on histology, but what you can help is by appropriately classifying these tumors into morphologic entities and doing some immunohistochemistry, you can suggest some further genetic triaging of these patients that can help in future patient care. So I think I'm not going to talk about parathyromatosis because nothing has changed here in the WHO 2022. This is just abnormal parathyroid tissues. You see in the soft tissues of the neck and mediastinum. Just to summarize what I just talked, WHO 2022 update in parathyroid, change in nomenclature, primary hyperplasia replaced the multiglandular parathyroid disease because consider them as germline susceptibility-driven manifestations of these MEN1, MEN4, MEN5, or CDC73-related genes. Atypical adenoma is now called atypical parathyroid neoplasm. Addition of parafibromin deficient neoplasm, it could be an adenoma or an atypical parathyroid tumor or a carcinoma. If you see absent parafibromin, then they should be classified as such. In parathyroid carcinoma workup, do immunohistochemistry for Ki67 and others. I said others because in addition to parafibromin, others are good to have, but they're not really required. Document mitosis per 50 high power field or 10 millimeters square, and do the Ki67 labeling index, and do the fibromin immunohistochemistry. If it is negative, then you have to test for the germline mutation, classified as parafibromin deficient neoplasm. Thank you very much.